Yeah, good afternoon, everyone. Welcome to day two's proceedings of TCT India South Asia meeting. As you all know, we had excellent response and very good encouragement from all the colleagues across the country. We had about 5,000 plus regular registrations, routine registrations of watching on YouTube streaming, the platform streaming what we are doing, and about 1,000 of prime registration. This time, Ferenc, we started, welcome Dr. Ferenc. And this time we started streaming this on to show the live cases which are done on the bigger screens. We evolved the system, what we called it edutainment. We stream all the proceedings on the PVR cinemas, the cinema theaters across. And with following all the COVID precautions, we didn't want to choke the theaters, but about 50 to 60 in each, about 150 seaters. We requested some of the colleagues enjoyed it yesterday. And we're doing it in about 9 hubs across the country. India is a vast country, as you know. In Delhi, Chennai, Bangalore, Hyderabad, 2 places. Hyderabad response was good. We started in 2 places. And some of the glimpses we would show you in the highlights video which we made when the time permits to us. And this platform also is wonderfully done. I will show some details of it. We get some time in between the live cases. As the speakers have already joined and they're waiting, I wish we could start the sessions. And yesterday we had entire program on the India Valve, we call it as TCT India Valve session. We had good live demonstrations which came from US, from Raj Makkar, and London, Dr. Ganesh Manohar, and Eberhard Grube from Germany. And then India, Dr. Ashok Seth showed it from Fortis Escorts. And we had also sessions live in a box type case coming from Trans-Radial, and we showed one. In the end, Dr. Sai Satish showed an excellent mitra clip case, which was very well demonstrated. And some of these bits pieces I will highlight, present to you in the video after some time. Thank you, Ferenc, for joining dot on time. And thank you, other speaker colleagues. And I see Dr. Sanjay Chung sir also joining, and Dr. Manjunath sir joining. Welcome, sir, to Day 2's proceedings. Dr. Manjunath sir was there in the inaugural session in the last year. I remember when we opened the conference with Antonio Colombo. So
thank you, Dr. Srinivas.
Always encourage it, sir. Thank you, sir. And this other panelists who have joined, I think they will join on. Dr. H.K. Bali, Dr. Dugal, Dr. Raghu. I saw Raghu already, other Ramesh, and Jabir and Madhu Sridharan. Welcome all. And with this, I request Dr. Ferenc and Dr. Sanjay Sukh sir to take over. We have lectures in the first session, followed by 2 live cases coming up from Apollo Mumbai and Ruby Hall Clinic Pune from Dr. Hiramat. Over to you, Dr. Ferenc.
Yeah, Dr. Srinivas, very thank you for the invitation. I'm really very glad to see you again. And so I think your session today, according to the vascular access, is really very important, because we have to plan the access, we have to perform it perfectly. And we know now from a lot of data and also our personal experience how important this perfect access of femoral access, how important it is to avoid bleedings, because this is a crucial point of whole procedure part. So I'm really very happy to have with me in as other chairperson, Dr. Sanjay Choi. I hope I pronounce you right. And we have in a panelist, Dr. Bali, Dr. Dugal, Dr. Raghu, Dr. Ramesh, Dr. Abdullah Kuti, and Dr. Sridharan. And we would start with our session with the first presentation of Dr. Atul Abhyankar. Please welcome. And his lecture will be railway catheter and other newer radial access devices and techniques. Please welcome, and we should start now.
Okay.
Thank you. First of all, thanks for inviting me to talk into this very prestigious meeting. I hope my slides are visible. I'm trying to go to screen show. Okay, so I will be talking about a new sort of way to do radial interventions in terms of the access, and mainly talking about railway catheter, and then somewhat about the glide sheath slender by Terumo. So we know that transradial PCI has become a preferred access because it reduces major adverse cardiovascular events, reduces bleeding problems, it increases the patient comfort, and is associated with decreased mortality in ACS. However, we do know that there are still some limitations of transradial approach, and they are mainly spasm, significant pain, radial artery occlusion, which may be either symptomatic or asymptomatic, which makes also the difficulty of reuse of radial artery for future interventions. And the major limitation is to perform the intervention because of the inability to use a larger size of guide. When it is even 6 French, when we have very small radial arteries, and difficulty of 7 French in practically majority patients. Now, if you consider all these limitations and complications finally are related or largely related to the radial artery size, and it is responsible for each of the limitations that I just mentioned. This is the bell-shaped distribution curve of the radial artery diameter, and this is international data, but probably in Indian population, this top of this bell probably would lie somewhere here. It's about 2.3 and probably not 2.5 or 2.6. Now, if you look at the conventional PCI sheets, they are simply too large for a significant, almost half of radial arteries. So this is a graph showing various sheets. These are the radial artery diameter, that is 2.32, which is probably the mean Indian diameter of radial artery. And this is the outer diameter of the sheet. So if you look at any of these sheets, they are significantly larger. So the outer diameter is 2.7, 2.9. Now the best sheet that I'm going to talk about in the end is the Terumo glide sheet slender, and even that has a 2.46 millimeter diameter. So 44% of radial arteries are smaller than 6F sheets, which is the kind of guiding, which is the size of sheet that most of us would use. And this expansion of radial artery that we have to do because of that results in various complications, which I have already mentioned. Now, the mechanisms of transradial PCI failure, if you take the major of them, that is the radial spasm and radial dissection, so these 44% together are attributed to radial spasm or radial injury, which again is related to the size of the sheath or size of the catheter. So larger sheath size is a predisposing factor for radial artery occlusion. The vascular damage that you cause because of the large size causes endothelial injury, reduced flow velocity, platelet activation, and coagulation cascade. So in a meta-analysis of 66 studies, the occlusion occurred in 11% with 6F sheath and 2% with 5F sheath. So 5 to 12% of transradial catheterization patients develop radial artery occlusion, and the incidence is higher from 6 versus 5. So compared to 5F sheath, if you use a 6F sheath, the incidence is 5 times higher. And a sheath to artery ratio of less than 1 is crucial for that preventing occlusion. However, that is extremely difficult. Instead of going into the details of statistics, I'll just mention that 20% of males and 40% of females have radial arteries which are smaller than 6F sheath. I think this is the most important slide, which will show you the crux of the matter and the entire concept. And that is, these are the sheath diameters. These are the guiding catheter diameters. So if you look at a 6F sheath, it has an outer diameter of about 2.52 or even 2.62. Whereas if you put a guiding catheter without the sheath, then the outer diameter is only 2.31. So it is even smaller than the 6F sheath through which you are going to use a 6F guiding catheter. When you use a 6F guiding catheter, then the outer diameter is only 1.98 as compared to a 5F sheath, which is 2.28. So it is even smaller than the 5F sheath. So when you're using a 5F sheath, you're actually, if you use directly a guiding catheter, then probably you are making a smaller puncture or you are not dilating the renal artery. So this is the system which is called railway, which enables a nearly 2 French entry profile reduction compared to the conventional sheath. So this is by eliminating the sheath altogether. So now I will just go through just briefly about how to do the procedure. The first step is there are 2 dilators available in the kit. Now when you are doing is starting with the puncture, that means you are approaching directly for intervention. Then first what you have to do is, this is the dilator, this is the green color dilator, which you load into whichever guiding catheter. So there is no limitation of which guiding catheter you wish to use. So whichever guiding catheter you want to use, you preload this guiding catheter with this dilator. Now then you can puncture with whatever technique you use to puncture. There is a wire available in the kit, but one can use the wire that one regularly uses in practice. So after having done the puncture as is routinely done, on that wire, the dilator, which is already inside the guiding catheter, now you thread this dilator over this wire into the puncture into the radial artery. Now the wire exits from this port near this marker, and I think you can see barely this wire here, and this is where the guiding catheter starts. So basically this is the guiding catheter there, this is the dilator which is now directly entering into radial artery, and you hold this wire and push the entire system. So you don't need to have the wire going further all the time. You can keep pulling back, or you can let the wire proceed a little bit further. Now, as you proceed with this, what will happen is that now your dilator, this part is nearly about to enter the radial artery. Now, obviously, you have to take this wire out. So you pull this wire out and then directly insert the guiding catheter, because it is now on the dilator. So it is very easy to push this guiding catheter directly into the radial artery. The procedure is extremely smooth. It is as easy as putting in a sheath inside the radial artery. So now once you thread you insert the guiding catheter through the puncture into the radial artery, now this dilator needs to be pulled back as soon as you have a reasonable amount of guiding catheter inside the radial artery. Once you pull out this the dilator from the guiding catheter, then you introduce, as seen here, a normal 3.5 or 3.8 or Terumo or whatever wire you normally use after doing the puncture to take the guide into the upper part of artery and subsequently near the coronary artery. So from here onwards, the procedure is similar to what is conventionally done in any other procedure. So this is, we have no sheath whatsoever. Now there will be 2 questions. So after this catheter is completely inserted, you remove the guide wire and continue with the procedure. Now the 2 questions that come to mind is, what if you have already done a 5F puncture? That means at the time of doing, obviously one doesn't know whether we'll proceed with intervention or not. So maybe we would have done a puncture with 5F sheath. Now, even if that is done, there is another type of dilator that is available in the kit, which can take a 3.5 wire. The other aspect also useful for this other dilator, which takes a 3.5 wire, is when there is a double vessel disease. So if you put one guiding catheter already there, you finished with one vessel, and now you want to exchange to another guiding catheter, or for that matter, if your first guiding catheter does not sit well, for some reason you want to change the guiding catheter, you can use this 3.5 wire compatible dilator or the inside sheath to thread the guiding catheter. So there are 2 types of dilators. One I showed you in detail for purpose of just explaining to those people who might not have used this. This is extremely comfortable procedure. So till now, we have done about 45 PCIs using this route with direct guiding catheter approach, which consisted of 29 males and 16 females. The guide size that we used was 7 French in 6 of them. And in 3 of these patients, we did a left main bifurcation with kissing balloons. And for our Indian colleagues, we all know that we many times have to use used balloons, and we can't really do kissing balloon and all from a 6 French catheter unless there are smaller size and newer balloons. So this allows a bifurcation procedure to be done with a 6 French size puncture. So what 6 French size you would have used otherwise, using the same size of puncture, you can do a left main bifurcation. We did not have any problem with radial artery occlusion. There was a considerable procedural difficulty in 2 patients because of spasm, because we know that it can occur even when you're putting a diagnostic catheter of 5 French, it can happen. And there was not a single procedure needed a switch over to femoral because of inability at any stage. Now, I'll lastly mention about the other way. If you don't have a railway system,
Atul, I think we have finished the time. We'll have discussion during the live case also, if you don't mind.
Just I'll just show one slide, maybe.
Okay.
So the principle remains the same, and this is the crux of the matter. What happens in the glide slender sheath is that the sheath thickness is reduced from 0.20 to 0.1.
Next talk is on this same thing, sheets. The Dr. Rafat Shaukat will show these sheets and the other things. If you have to show one slide, sorry, you can go ahead. Otherwise, next talk.
I just thought I would just. So I think rest of this thing is just data. So I think I will skip that. And this is just the last slide showing that you can have a much smaller outer diameter of slender sheath to perform the radial procedures. And if the next probably talk would explain that. So sometimes small could be safer and satisfied. Thank you.
Thank you.
Okay, thank you so much.